nausea, vomiting, hiccups, very important, ataxia, gait dysfunction, bladder dysfunction, all that might direct you to NMO, neuromyelitis optica. Also make sure to ask about headache, malaise, fatigue, seizures, or fever, which can also direct you to ADEM, which is acute demyelinating encephalomyelitis. And we will go through those diseases in a minute. Also, during assessment of a child with optic neuritis, remember to check for lymphadenopathy, hepatomegaly, splenomegaly, which might suggest a possibility of infectious mononucleosis or cat scratch disease. Look for systemic signs of vasculitis. Ask about skin lesions to rule out SLE. In examination, as we said, visual acuity will be reduced. You might find relative afferent pupillary defect if the case is unilateral, and you might find some visual field defect if the patient is old enough. In fundus examination, usually there will be papillitis. It was reported around 50 to 70% of children will have papillitis, and if we compare it with adults, we know from the optic neuritis treatment trial that's only 1/3 of the patient will have it. So the majority of in adults will have retrobulbar optic neuritis. OCT can provide assessment of a neuronal injury, including retinal nerve fiber layer thickness and retinal ganglion cell body. We always have to remember that we don't have yet normal data of patients in pediatric age. However, it's important to do it so we can assess the progression of the thickness of nerve fiber layer. We do MRI brain and spine in all patients with optic neuritis, and frequently we also do lumbar puncture. Mainly, the lumbar puncture is performed to rule out increased intracranial pressure in cases of bilateral when we are not sure if it's papilledema or bilateral optic neuritis, and to rule out if there is any signs of meningitis, encephalitis. And to check also for the oligoclonal bands. So when you have a patient with bilateral optic neuritis, sometimes you're in a dilemma of whether this is optic neuritis or papilledema, especially when the patient presents also with headache. So the findings supporting the diagnosis of bilateral optic neuritis will be a decrease in the central vision, severe dyschromatopsia, and large non-reactive pupils. Sometimes if the patient have papillitis, you might see some vitreous cells, mild vitreous cells. The visual field, when possible, shows central scotoma and optic neuritis in comparison to increase and enlarge blind spot with peripheral reduction of field in papilledema. If patient with lumbar puncture and opening pressure is high, that does not mean that the patient have papilledema. In one study, up to 25% of the patient with optic neuritis actually have elevated opening pressure. Therefore, when you are in face of such patients, keep several findings and add them together to give you the diagnosis. MRI finding is important. It can show you some of the signs of increased intracranial pressure and can show you also enhancement in cases of optic neuritis. Optic neuritis in childhood may occur as a monophasic illness. It can occur as a recurrent, but again, isolated optic neuritis, or it can come with the context of multifocal inflammatory CNS diseases. So when you present with optic neuritis patient and has multiple neurological signs, consider the diagnosis of multiple sclerosis, acute demyelinating acute demyelinating encephalitis, or NMO. This is an algorithm that might help you sometimes when you're in face of patient with acute optic neuritis. So basically, I'm not sure if it's very clear, but basically we depend mainly on the finding of the MRI, if it's normal or not, and if the case is monophasic or recurrent. And based on that, we go through the chart. If the patient has a monophasic optic neuritis, it might be a post-infectious optic neuritis. Usually those patients will present with a febrile or flu-like illnesses preceding the optic neuritis by days or weeks. The most common viruses associated with it is measles, mumps, chickenpox, rubella, infectious mononucleosis, cat scratch, toxoplasmosis, and enteroviruses. Immunization also is associated with those optic neuritis, including diphtheria, tinnitus, which all might precipitate optic neuritis in children. The delay onset of post-infectious optic neuritis after recent infection or immunization and the bilateral involvement in most of those cases suggest a generalized mechanism of injury rather than a random viral invasion of optic nerves. Therefore, we believe that post-infection optic neuritis is autoimmune rather than a direct invasion of the virus toward the optic nerves. What about multiple sclerosis? Optic neuritis is the initial episode in about 1/3 of pediatric with multiple sclerosis. It has been suggested that a mix of abnormal immunological response, possibly precipitated by infectious agent, in a genetically susceptible individual lead to optic neuritis and multiple sclerosis. Some of the recognized risk factors for developing pediatric multiple sclerosis has been Epstein-Barr virus, vitamin D deficiency, and positive HLA-DRB1. CSF oligoclonal bands were found in about 80% of patients with pediatric optic neuritis that is associated with multiple sclerosis, in comparison to only 15% in patients who presented as a monophasic optic neuritis. Studies has showed that abnormal finding in MRI and the presence of oligoclonal bands and older age predict the conversion of MS. In one study, they showed that if a patient presented with finding in the MRI and positive oligoclonal bands, there is a 27-time increase of risk of having multiple sclerosis than other patients. Complete visual recovery after their initial injury is usually common. In pediatric multiple sclerosis, eyes with a history of optic neuritis have been reported to have less 10 to 20% thinner retinal nerve fiber layer thickness than patients with MS without optic neuritis and with control eyes. The other entity that we have to think of in pediatric optic neuritis is acute disseminated encephalomyelitis, which is uncommon inflammatory demyelinating disease of the CNS that usually follow a viral illness or vaccination by days to weeks. This disease predominantly affects children and young adults. The average age is 6 to 10 years old. ADEM is considered to be monophasic illness. So when you have a child who has a recurrent attack, think of something else. A wide variety of viral infection trigger has been reported, including influenza A, Epstein-Barr virus. Usually, the patient will present with history of fever, fatigue, headache, nausea, vomiting, and additional neurological signs, including hemiplegia, ataxia, and seizures. The clinical criteria for ADEM is to have a patient with the first-time attack of polyfocal clinical CNS demyelinating symptoms. He should have encephalopathy that cannot be explained by fever, no new clinical or MRI finding beyond the 3 months after the first attack, and an abnormal MRI brain within the first, again, 3 months. Usually, the MRI will show a diffuse, poorly demarcated, and large lesion involving the cerebral white matter. It is very rare to have a T2 hypodense lesions, such as what we call the black holes that's common in MS. And there is a deep gray matter lesion, mainly at the thalamus and basal ganglia. So this is one of the patient, and you can appreciate the difference of those lesions than the usual MS lesions. You can see they are moderate to large area of increased intensity. And it corresponds to the inflammation and demyelination associated with this disease. On the other hand, it's also another patient with the same disease. However, it shows multiple diffuse round patchy lesion, and sometimes those kind of lesion will be difficult to differentiate from the MS lesions. Again, the hypothalamus and basal ganglia involvement will guide you to the ADEM diagnosis. As I said, MRI may show significant overlap between the ADEM and the multiple sclerosis, and thalamic involvement might be useful in imaging sign because it's rarely seen in pediatric MS. One of the differentiating signs between ADEM and MS is the age. Usually the patient who will present with optic neuritis associated with multiple sclerosis will be older in age, while the ADEM younger. The signs, usually multiple sclerosis will be as an isolated neurological, while in ADEM there will be multiple neurological signs. The CSF, usually they will present with lymphocytic polycytosis and protein elevation, and oligoclonal bands were present in comparison to MS, where it's 40 to 95% present. The MRI lesion, we just discussed it. Important also is the follow-up MRI. In the ADEM, there should be no change, or at least there is resolution of the prior lesion. In MS, usually the patient will show some new active lesions, even if they are clinically silent. ADEM is an urgent condition. It has a mortality rate of 5%. Usually the first-line treatment is systemic steroids. However, IVIG and other immunomodulatory agents can be used with apparent benefits. The third entity is neuromyelitis optica. Neuromyelitis optica is an autoimmune disease of the aquaporin channel, and it's caused causing recurrent episodes of optic neuritis and transverse myelitis. There is aquaporin 4, IgG, in the serum, which target the astrocytic water channel aquaporin 4. This antibody was discovered 2004 and was considered an advancement because it has very high sensitivity and specificity for this disease. Children account for up to 10% of all cases of NMO. 88% of seropositive patients are girls, and the presence of aquaporin 4 immunoglobulin IgG is associated with early recurrent and visual impairment. There is also high prevalence in African and Caribbean descents. It is important to remember that many cases of NMO will present with bilateral optic neuritis, and they will have severe visual loss. The optic disc may be normal or swollen. There is no much difference. And they will have severe retinal nerve fiber layers in comparison to the typical optic neuritis associated with multiple sclerosis. Also, there's been reports of microcytic changes in the inner retina as compared again with multiple sclerosis patients. NMO, finding mainly in MRI, is longitudinal involvement of optic nerve that usually will start from optic nerve, involving the chiasm and sometimes even the optic tracts. In adults, the NMO usually have MRI approximately normal with no much lesions. However, in pediatric NMO, the subcortical white matter lesions are common. Sometimes it's difficult to distinguish NMO, MRI from an MS, especially early stages of the disease. The CSF in the NMO typically show polycytosis and increased total protein, and this is mainly due to a blood-brain barrier defect. Again, the oligoclonal bands are almost absent. The revised diagnostic criteria for NMO, which was published in 2006, indicated that if we want to label the patient as NMO patient, patients should have first optic neuritis, they should have acute myelitis, and they should have 2 of the 3 criterion from A, B, and C. So either they have extended lesion, spinal cord lesion, more than 3 vertebral segments, they should have an MRI brain that does not meet the diagnosis of multiple sclerosis, and they should have an NMO IgG positive status. Because of the new advancement in the detection of the NMO antibodies and the better sensitivity of the test, there are many patients with, for instance, optic neuritis and positive NMO antibody without acute myelitis, and therefore we cannot really call them NMO. So in 2007, NMO spectrum disorder was introduced, and by 2011 to 2013, an international panel of experts of NMO gathered to put the criteria of NMO spectrum disorder. And we can say it's extensive. I don't think the lecture, we will go into much detail in this lecture. However, if you're interested, this article is very good and has a comprehensive discussion of NMO spectrum disorders. The mortality of NMO patient is around 20% if not recognized early. The main cause of mortality is respiratory failure due to cervical myelitis. Steroid is the first line, and usually when we give steroid, we have slow tapering, followed by plasma exchange if there is no response to steroids. For prevention of further attacks, Rituximab usually is advocated as the first line of immunomodulatory treatment. And it has been shown that it decreased the accumulative attack-related disabilities. It is important to remember that the current therapy of multiple sclerosis, such as interferon B and fingolimod, can exacerbate the course of NMO. Therefore, if you have a suspicion and you're not sure if this is an multiple sclerosis or NMO, make sure before starting the patient on multiple sclerosis treatment. We know that the visual outcome in general in pediatric optic neuritis is very good, despite the initial severe visual loss. Usually the improvement of the vision will begin within the 3rd week of presentation, and it will maximize by the 6th month. In a retrospective analysis of around 60 patients with optic neuritis, they found that by 1 year, 80% of them had a vision of 20/20. And 95% of them had vision better than 20/40. They also noticed that poor visual outcome, which is below 20/40, was associated with vision loss less than 20/20 in 3 months. Therefore, at presentation, you cannot really have the idea whether those patients will have good visual outcome or not, regardless of their presenting visual acuity. It's actually after 3 months, you can give them a hint of their prognosis. There was no association found in regard of visual acuity at presentation or the degree or severity of optic disc edema, or if it's bilateral or unilateral. As in adults, in acute stage of optic neuritis, there will be VEP amplitude reduction and latency delay, mainly due to demyelination. The VEP returns to normal in around 55% of the cases, and this is in general much higher than in adults, and this might indicate a greater potential for remyelination in children in comparison to adults. In regard to treatments, unfortunately, we don't have a clinical trial to show us the efficacy of different treatment modality. What we usually do, we give IV methylprednisolone 15 to 30 milligram per kg per day, and make sure that the maximum dose he receives is 1 gram daily for 3 to 5 days, followed by oral steroids. The optimal duration of oral steroid is also not clear, as children were not included in the optic neuritis treatment trial. One study showed that there is no outcome difference between the children who had shorter course of steroids, less than 2 weeks, in comparison to patients who had longer course of steroids. There is small case series that have described the success of IVIG treatments and plasmapheresis in patients not responding to corticosteroids. I hope by this time I highlighted some of the points to prove to you that the pediatric optic neuritis is fundamentally different from the adult optic neuritis. Basically, pediatric optic neuritis is common to be bilateral, more common to be associated with optic disc swelling, greater visual acuity deficit at presentation, and more likely to develop bilateral eye involvement than adults. Our understanding about pediatric optic neuritis, the natural history of the disease, the response to therapy, and to the prognosis and associated risk of MS is all based on case reports and retrospective studies, in addition to generalization from adult studies. Unfortunately, we don't have a prospective controlled trial in pediatric optic neuritis. However, in 2016, the Pediatric Optic Neuritis Prospective Outcome Study was launched. Their primary aims are to determine the feasibility of enrollment of pediatric optic neuritis for a treatment trial and to measure the clinical importance outcome in a prospective study cohort in children with optic neuritis. Mainly, they will focus on focus of visual acuity, OCT results, and the risk of conversion for multiple sclerosis. And hopefully, the study will provide us with needed prospective data regarding this condition. Thank you. Any question? So, optic neuritis clear? Yes, I can. Yes. Yeah, we don't have evidence. However, usually we generalize it to adults. We don't give oral without IV. The controversy is whether to give it as adults, 11 days with tapering of a total of 14, or to give it as extended period. A lot of physicians who's dealing with optic neuritis in pediatrics, they believe that they have a higher risk of recurrence, so usually they taper it over 3 to 4 weeks rather than a short course of steroids. However, as I said, we don't have really evidence supporting this. Yes. Usually those patients will present with bilateral, with severe visual loss. Always we have to ask of transverse myelitis signs, if the patient has ataxia, bladder dysfunction, or in MRI there is extensive demyelination. As I said, involving an optic nerve, chiasm, sometimes reaching to the optic tract. This is not a typical sign of demyelinating optic neuritis in relation to multiple sclerosis. So those are some of the hints that guide us. Yes. The main treatment is steroid. However, if you're suspecting NMO, I would suggest to give it for a prolonged period and to send it for pediatric neurologist if there is no neuro-ophthalmologist. Send for the NMO IgG antibody because it's very sensitive. So if it came to be positive, so you're 99% sure that this is NMO and you have to put him on immunosuppressive treatment rather than multiple sclerosis treatment. Okay, thank you very much.
بدر كيف الآن؟ في شيء يعني فكيت شيكت على الوضع الآن، فكيت لكن فكيت شو اسمه.
هلا علي، هلا والله. الله يسعدك. مويه. لا الحمد لله كل شيء.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Good afternoon, ladies and gentlemen. I would like to welcome all of you to this grand round. Today's talk is about surgical rejuvenation of the periorbital area. Today's speaker is the well-distinguished, well-known professor of ophthalmology and oculoplastic and orbit surgeon, Dr. Adel Saibani, the chairman of ophthalmology department, King Abdulaziz University Hospital and King Saud University. Personally, I've always enjoyed and learned from Dr. Saibani, whether it's a functional talk or an aesthetic cosmetic talk. So I would like to invite all of you to do the same. Thank you very much, Prof. Adel. The floor is yours.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wassalatu wassalamu ala Sayyid Muhammad. Thank you, Dr. Hattam, for this really introductions that I'm not sure if I deserve it or not. Before I start, really, choosing a grand round topic is really not an easy job, especially you are talking to ophthalmologists, and many of them are senior to me. So I thought cosmetic part, we are not really talking much about it. So it's good to give you some flavor of what we do for rejuvenating the periorbital area, especially now the demand for cosmetic procedures, especially surgical and non-surgical, are really increasing. Before I start, really I'd like to make a really statement that I hope you agree with me. In the periorbital rejuvenation, our aim is to make the patient, or not patient, make the people better, not different. And for me, and many people believe in this, the really key success for any procedure you do for rejuvenating the person, he or she, when he or she comes after the procedure and tells you that people looked at me and they told me, oh, there is something different, or you look better, but they cannot figure out what did they do. For example, did they do upper bleph or lower bleph or something else? This is really a success because you're making the patient or the person look better, but not different. And this should be the aim for cosmetic surgery and rejuvenation, not to make people look different, to make them look better. With this introduction, I'm gonna just, because of the topic is so huge, so I'm gonna just make focusing on upper eyelid and lower eyelid rejuvenation surgical procedures only. There are a lot to do about Botox, fillers, and brows, so maybe we'll do it in another occasions. When you get a patient for upper lid blepharoplasty, is my sound clear or what? We need to, there are like several checkpoints, but here I'm going to touch a few points that I think is really important to keep in mind when you work a patient for upper lid blepharoplasty or rejuvenation in general. You need to address facial asymmetry, which is very common among people coming for a cosmetic procedure. They come to you and you are the first person to show them the facial asymmetry, which is really a common normal variation among people. Also, you need to grade the dermatochalasis. Look at the muscle tone, because you don't want the patient to develop after that lack of thalamus or other issue that really challenging to manage, and it's not good to go in that direction. Skin elasticity is really important thing to look. If we got different ages, they have different elasticity, plus people exposed to the sun, different than people not exposed to the sun. So something good to keep in mind. Look for the lacrimal glandular prolapse, which is very common among people coming for cosmetic surgery. It's really important to manage ptosis ahead of time, not to discover it after the procedure, because if you discover it after the procedure, the patient will blame you for it. But if you discover it before and show it to them, they will agree on you, with you either to go for correction or you just leave it alone. Past history is really important, especially for cosmetic procedure. If you don't ask about it, people don't volunteer for it. And I'm sure many of you have seen in the emergency room people coming with ptosis because of Botox injection, but they don't tell you this. So if you don't ask for it, they don't volunteer, especially if something, if it's done without the approval of the other partner, male or female. So they tend to hide it. So if you don't look for it and fish for it multiple times, and sometimes we need to ask in private, you may miss this one. And history is really important. I'm going to mention a few occasions where history is really important in my talk. I put the last one, which is the most important, is the patient concerns and expectation. Don't correct what you think is important for you. Correct what's important for the patient. And maybe you'll use more of customers or people because we are not treating with patients here. Okay? Here is a good example to show facial asymmetry. As you can see, this patient came to correct her brow. But if you look at her face, there is a really significant difference. If you look at the brow here, the orbit inlet here is a smaller. If you look also for the cheek is different. So raising the brow itself will not change the whole picture. Patient still will be having facial asymmetry, and they need to be aware of this. Otherwise, the patient will continue being unhappy, or the person will be continuing unhappy. Other important issue when you evaluate the patient, look for other things that we are really expert, but the plastic surgeon may not an expert. Like this patient, she came because of her eyes looking abnormal, or she thinks there's facial asymmetry, but well, actually she's having a large globe. So when you have a large globe and explain to the patient this is the reason for abnormality or the concern she has, you need to understand what options. And this patient, I did for her fat decompression, so the large globe went back a little bit, and she was happy with that. So this is one of the options you can discuss with the patient. Now with the trend, we used to do more surgeries, and this is one of the good example for it. This patient came because facial asymmetry. You can see the skin folds here, but no skin folds here. And one of the trend now in oculoplastic, and often becoming widespread, is using fillers. Because the trend now to do surgery as much as possible, especially with the really good outcome, we get fillers. Look at this patient after injecting the left eye, the superior sulcus with the filler. You see how much improvement you get? What we used to do before, we used to excising the skin here, so this one will simulating the other one. But now if you look at the sign of youth, you see the superior sulcus is full, not empty. And this is the trend now, is to make things not deflated, more of a young or youthful face or youthful appearance. This is one of the things that I really stress in history, because this patient had a permanent filler injection and came for blepharoplasty. If you don't dig in history and recognize that she had a permanent filler, and you know that permanent filler can migrate, this patient had a filler injected in the malar area and migrated to the upper lid. So if you don't dig in history and know what really exactly happened, you will get in trouble. And this patient, she had a filler, and this is what you see. What you see is bulging here. It's actually a filler, not a fat. So it's something good to recognize before and discuss with the patient what option and what complication can go through with the permanent filler. Lacrimal gland prolapse is another common issue we see in patients seeking upper blepharoplasty. Like in this patient, you can see the lacrimal gland prolapsing. This is another patient, she had upper lid blepharoplasty, but the lacrimal gland was not addressed. And this is her picture. You see the lacrimal gland in the surgery is prolapsing here. You can see it here. And this is her picture after addressing the lacrimal gland. And you can see the change in the fullness here after reposition of the lacrimal gland. Other important issue is ptosis, so we need to recognize it early and treat it, and this is really important to address over time. This patient with left eye ptosis, and this is after muleirectomy. This patient is a chronic contact lens user, so she developed aponeurotic ptosis, so I do muleirectomy for it. This patient with congenital ptosis, which I do facial resection, I don't do much of muleirectomy because it doesn't work well in my hand, and this is his picture after surgery. Other thing is to look what the patient is better. This patient was kept saying, or people telling her that you have ptosis in your right eye. Well, actually what she has is, what she has is not. It's more of the ill-defined lid crease. So when we do limited blepharoplasty and excise the hanging skin over the lid crease, this is her picture after. So just small limited blepharoplasty made her happy. So you need to listen to the patient and to offer her the most reasonable and less invasive procedure to rejuvenate the face. This patient also, she came concerned. I was concerning about doing eyelid here and excising the skin, but what really was her concern, I want to get rid of this fat prolapse. And this is her picture after, and she was happy. So it's need to know what really concerning the patient. And this is when I do blepharoplasty. I'd like to extend it medially all the way here and also laterally to go around the orbital rim, because if you don't do that, you will have some extra skin hanging here and extra skin hanging here, and the patient will not be happy after that. And this is the typical patient we get for upper lid blepharoplasty. They come with some extra skin hanging over the eyelids, either lateral or medial, and this is her picture after. And this is a close-up. And this is another patient. She's worried about the fullness here, and this is her picture after surgery. Well, unfortunately, most of the patients I get referred with this condition coming from plastic surgeon and dermatology. Ophthalmologists, they don't pay attention to this. They look only for function, and they're waiting for a patient to reach this stage to refer for oculoplastic. Well, other specialty, they're more concerned about the way the patient look or the person look, but ophthalmologists, they're concerned about function only. So you don't need to refer the patient when reach this stage for blepharoplasty. You can refer the patient earlier, they can enjoy the better look. And this is her side view when you look at the referring the after excising the skin. And sometimes, the trend now is to preserve fat as much as possible. And the idea of this to prevent late complication or actually disfiguring of the patient. However, in some occasions, we need to remove some fat so the patient will will achieve the look they're looking for. And this is a good example for it. You can, this patient has some fullness and also some fat prolapsing. So if you don't remove some of the fat, the patient will not reach this appearance. So removing some of the fat sometimes is really important to achieve the patient or the customer goal. One of the common questions people ask when you discuss for them the surgery, what's the recovery time? And when can I go back to normal life? Normally, when I do upper blepharoplasty, I tell the patient if they can go back after 10 days or even earlier a little bit if they are using makeup to cover their appearance. And this is the patient appearance 1 week after. And you can see there is still some bruises here. So they can go 1 week after upper lid blepharoplasty to their normal life. One of the common things we get consultation for is epicanthal fold. And it's one of the most really challenging condition. After doing good number of them, I restricted my criteria, or actually I became more selective in doing this procedure. Normally, I look at the nasal bridge. If the nasal bridge is normal and normal arch, I can go for the epicanthal flow or medial canthoplasty. However, if the nasal bridge is flat and the nose is broad, I try to avoid that because what surgery you do, the patient will not be happy. Other thing I look for is the skin type of the patient. If the people are really like my skin, the scar is easy, be visible and not well covered, I try to avoid and warn the patient a lot before. Well, like in this patient where they have the good healing or the skin very forgiving for scarring, I can offer them the procedure. And this is a patient after I did for her the blepharoplasty with medial canthoplasty. Most of our patients, they don't come for follow-up. When you do the surgery, they just go, they don't show up. And this is her picture. She sent it to me over the cell phone, so I thought of sharing for you. So this is patient before, and this is patient after. There are many techniques described in the literature for epicanthoplasty correction, but I found this really a good technique, and I tried it in several patients. It's very promising and really a good outcome I get out of it. It's published in 2012, but still is really one of the best because some paper came after is not as good outcome as this technique described here. This is for the upper eyelid. So we're going to switch gear to the lower eyelid. It's really important to chart some of the anatomical landmark. And one of the important landmark in upper lid, lower lid blepharoplasty is the junction between the cheek and the lower eyelid. And here comes the important role of the orbitomalar ligament. And this one described by Dr. Don Kikawa. He the first to describe this ligament. This ligament, laxity in this ligament will make the lid lax toward the cheek and will create what we call double convexity. Along with that, there is other changes in the orbital septum, so the fat will be sagging behind, and also some descent and deflation in the malar fat pads. So these changes will lead to the changes that people come to seek for rejuvenation and surgical intervention. For upper eyelid blepharoplasty, again, before considering the patient for surgery, you need to look for facial asymmetry, grading the dermatochalasis. Muscle tone here is more important than the lower lid. Also, you need to look for skin laxity and lower lid laxity, because if you don't address that during surgery, the patient will develop ectropion or lid retraction. So it's good to treat it and address it during surgery. Also, good to look for any surgery or fillers injection before, and also important to address any dry eye symptoms before, because what happens, especially in the earlier post-op period, people, they will have abnormal blinking, and if they have dry eye to start with, that will increase their concern or their problem. Past history is another important that we just mentioned before, and also patient concern and expectation. That is really important. When you evaluate the patient clinically, it's good to look for eyelid laxity, lag of thalamus, mid-face dehiscence, and also double convexity deformity. Here just I'm showing something that's simulating fat prolapse, which is it's not that common, but I'm sure you'll be seeing it between time to time. What we call it fistones. Fistone is a form of edema below the skin, and it happens because of the weakness in the connective tissue below the skin. The exact pathology for it, it's not known, but people think that may be related to sun exposure or other changes in the skin. And this is the patient. You can see that there is a swelling here, and there is a swelling here. This is not fat. This is fluid. How you differentiate between the two? Ask the patient to look up. When the patient looks up, you can see this one is not changing. It's the same size. If it's the same size, that means it's a fluid and it's not in the orbit. However, if it's fat prolapsing, when the patient looks up, it will be bulging forward, okay? Now with the widespread of fillers, many people are treating the lower lid convexity, especially mild one like this, with the HA filler, which hyaluronic acid filler. So you inject it in the tear trough, and also sometimes we go laterally, and this will address patient concern. However, if it's a major changes, filler will not be enough for them, and they need to go for surgical correction. Lower eyelid blepharoplasty can be done through the conjunctival approach or through the transcutaneous or skin approach. So you need to work up your patient and see if they need skin to be excised. It's good to do it transcutaneous. If they need only fat treatment or fat reposition or excision, you can do it through the transconj approach. As we mentioned before, now the trend for surgery is to preserve tissue as much as possible, and the fat is one of the viable tissue that really rejuvenate the patient, and we should keep the fat and try to preserve it and use it to make the patient look younger as much as possible. And from this concept, now people are talking about fat redraping or fat transposition. And this is what they do. They move the prolapse fat here, and they move it over the orbital rim, so it will obliterate the depression below the fat prolapse, and this will change the double convexity to be one plane. You can do a transconjunctival approach, like in this picture shown, or you can do it transcutaneous, which hopefully I have time to present it in a video at the end. And this is what you do. Normally we transpose the medial and central fat pad. Lateral fat pad, normally the prolapse one, we excise it because we don't need fullness in the lateral because it's not sign of uterus. And this is the patient after surgery. This is her picture before, and this is after fat transposition, transconj. And you can see it from the side, it will be more appearing. So you can see the depression here and the fullness more equalized with the fat transposition. There is some patient who had extra skin, plus they have the fat prolapse, and these patients need to go for transcutaneous, so you can address the skin, you can tighten the skin at the same time. And you can see this patient has a little bit more fat prolapse here. So this one I excised part of it, and the other part we did transposition for her. You know, one of the important issue I want to show you here, you can see one of the aging changes we mentioned, that descent, and this is, you can see it in this patient. You see the eyelid is the length from here to here. So this is not sign of youth. Usually younger patients, they have shorter length of the eyelid. So we need to address that during surgery. And this is another good paper about how you address this one. It's what you call transcutaneous lower eyelid blepharoplasty with orbital malar suspension. It's a retrospective case series of 212 patients. This is again published by Don Kikawa and his group. And he popularized doing what you call it mid-facelift by tightening the orbital malar ligament. And this is what they propose in their paper. To reach that one, you need to free all the attachment of orbital malar ligament that I just point to you. And after that, you tighten it at higher level. And this is another picture. So what happened? Here you release all the orbital malar ligament. Typically, you need to go around centimeters treating the... one of the issue and challenge to manage patients with fistones and blepharoplasty. So patients need to know that the edema, it may really get worse initially, but it improves gradually, but it's going to take long time to improve. So patients need to be aware that the recovery is not going to be as patient without fistones. And this is a good example for it. This patient had here fat prolapsing, but this is a fluid. This is fistones. And this is after surgery. There is some fistones here. The typical treatment for this one, you go and excise the skin directly, but many people, they don't accept this. They don't want scar to be apparent. So the only way to hide the scar is to go below the eyelashes, or what you call a subciliary incision. And this patient accepted before, after discussion. One of the things that unfortunately we see between time to time is this patient. This patient had history of what? Permanent filler injection. And these patients, they come years after surgery. It's not like 1 month or 2 months after filler injection. They come, this patient, she came 4 years after filler injection. And the bad thing about filler injection, the permanent one, not the temporary one, that it migrates. So all the injection was done here. You see there is some fillers here if you pay attention, and also here. So it migrates, but it takes years to migrate. So it doesn't migrate in a few months duration. And this is her picture after excising it. Sometimes you can combine reconstructive with functional, reconstructive with rejuvenation. This patient with facial dysmorphism and a dysmorphic feature, and this is her picture before surgery. She had significant ptosis, plus the lateral canthal tendon is displaced down a little bit, and this is her picture after 4 lids blepharoplasty with ptosis correction. Surgeons don't like to talk about complication, but complication is there, and if you're not prepared for it, you will be surprised by it one day. So it's good to think about it and think what kind of complication can happen from any surgery and prepare yourself to avoid them. And as we all know, that prevention is better than treatment. So why the complication happens, there are several factors for it, but I'm going to mention the main reason for complication, which failure to recognize our lid laxity, especially in the lower lid, excessive skin removal, improper skin removal, excessive fat removal, or using a lot of cautery during surgery, or improper surgical technique. For example, you do a procedure for patient or for a indication is not really the best indication for it, and also skin pigmentation is one of the complications. This is one of the patients we see, alhamdulillah, rarely, especially if done by people who are not expert or not well trained on it. This patient had transcutaneous blepharoplasty for both lower lids. This patient ran this problem for 2 reasons. One reason, the lid laxity was not addressed well. Other thing, when they did the transcutaneous approach, they didn't respect the orbicularis muscle. And this is one of the major problems for having this issue. When they do the blepharoplasty, they don't respect the plane, and they do a lot of damage to the orbicularis muscle. And this is one of the main reasons why people are moving from transcutaneous approach to transconj approach to avoid damage to orbicularis muscle. And why people, they get scared from transcutaneous approach, because many of the lower lid blepharoplasty are done by plastic surgeon. And plastic surgeon they are not as gentle as ophthalmologists in handling the orbicularis muscle and doing the transconj approach. So the literature are full of this complication. So even ophthalmologists, they get scared, so they move to transcutaneous, transconj approach. So if you are doing the proper technique and choosing the proper patient, transcutaneous approach works beautiful. But if your technique is not well and damage to the orbicularis muscle happen or not recognizing lower lid laxity, you are fight this complication to happen. And this is his picture 1 week after tightening the lower lid and also doing limited mid-facelift. Other problem we mentioned about excessive fat removal. This is one of the sequel of traditional traditional blepharoplasty, which was based on removing a lot of fat. However, if you look at this patient, she is not rejuvenated. Actually, she is skeletonized. You can see the skeleton of the orbit. It's really disfiguring the patient. So more stress now in preserving the fat, so we don't reach this stage where the patient is really disfigured. One of the issues that it happens, especially in our area, is pigmentation, skin pigmentation. Patients need to be aware that it can happen. Fortunately, it's very rare, but it takes time to go. It may take like 6 months or so to go, especially in darks or in a patient with a little bit dark skin. One of the complications we see if you do, for example, blepharoplasty plus ptosis correction is overcorrection. And this is what happened to this patient. She wasn't happy because of the lid retraction here after correcting the ptosis, and also the skin was not removed in both upper lids. Other issue she was concerned is asymmetrical fat removal. So she had fat removed from this side more than this side. So the patient was not happy about the asymmetry. And you know, people coming for blepharoplasty, cosmetic, they are concerning about the details. So you need to pay attention to the details, because if you're not paying attention to the details, the patient will be behind you. They will come to your clinic every week concerning about it because they think this is the most important thing in their life. So you need to be prepared for the details. And this is her picture after. So we lower the lid for her in the lateral. Plus I remove some of the fat so we can have equal and excising some of the extra skin that left behind. And this is one of the problem also having the scar is obvious. And this happen mainly if a lot of skin removed. So when you remove a lot of skin, the scar is expanding. So you need to remove just amount skin, not over, not under. Because if you go over removal, you will end up with enlarging scar like in this patient, and she's not happy about. But if you move under, the patient will come to you and saying, oh, still there's some skin. So you need to take the patient back to surgery. So you need to really balance it. Another issue just I want to show you here, also this patient had a lot of skin removed here, but there is significant skin removed here. That's why I'm trying to tell you that when you do blepharoplasty, you need to go past the lateral canthal tendon and remove the skin all the way to the orbital rim laterally. Otherwise, the patient will come with this problem. And you can see what I'm talking about. You can see the skin webbing here because the skin was not excised from the start. So, before we conclude, just want to show you some videos. Let's show you how I do my fat reposition and also transcutaneous approach. So this patient for lower lid blepharoplasty, normally I start by traction suture. You can see it here in the lower lid margin and retract the eyelid. Then I start by making an incision in the lateral part of marked skin. Then I use a iris scissor. I dissect between the skin and orbicularis muscle with the aim of to have the orbicularis in front of the tarsus preserved, because the theoretical advantage of preventing lower lid ectropion later on. So I dissect between the skin and the orbicularis muscle here. Then I excise just under the eyelashes, because if you make it a little bit lower, patient will come to you saying, oh, there's skin obvious. So people coming for cosmetic, they're really concerned about details, so you need to prepare for it. Then I excise the skin. I try to minimize using cautery, and I try to minimize cutting skin tissue that I didn't need to cut. Then after that, I dissect between orbital septum and orbicularis. Then I keep orbicularis here in this area because they think it's preventing ectropion. This is the orbital septum here. Now I excise the skin and some of orbicularis with it. Then I use a Q-tip to dissect between orbicularis and orbital septum. I don't use cutting because really you don't need to. If you are in the right plane, use a Q-tip, it will dissect all the way to the orbital rim. And you can see the orbital rim here. You can see my Q-tip in the orbital rim here. So you can dissect, reach past by orbital rim without any scissor or any monopolar or any cauterization really. Then what I do to release the orbital malar ligament, I do incision just below the arcus marginalis with the 11 blade, or actually, yeah, 15 blade, sorry. Now releasing the orbital malar ligament, and there you go, subparietal dissection, all the way from medial to the lateral. For the lateral fat pad, usually I remove it because if you transpose it, it will not really appearing well after surgery, so it will be more bulging. So we just excise it, the prolapse part. I'm a little bit bloody surgeon, so I'm sorry for this. I don't use much cautery. Then for the medial fat pad, I open the capsule and excise just a little amount of fat with it. So this is a medial fat pad. Then I go for the, I'm sorry, this is a central fat pad. This is a medial fat pad. No, now I'm doing suture for transposition, but before doing the transposition, I need to free the fat pad from the inferior oblique muscle attachment. Otherwise, the patient will develop a double fission after that. So this is a medial fat pad. I'm transposition. This is the orbital rim. You can see the fat is now going over the orbital rim. It will be more appearing in the medial one, in the central one, because this is difficult to video. So I'm using a 6/0 phakial suture, because it will go after a while. By the time the fat is healed up and it's the new position. This is a medial fat pad. I'm sorry, why am I saying medial? This is a central fat pad. Yeah, pass through the fat. Then there is below the orbital rim, like a centimeter below the orbital rim, there is some fat pad from the malar fat pad, or sometimes to the muscle, so it will be fixed there. Then I connect the medial part of the central fat pad with the lateral part of the medial fat pad, so it will have a smooth contour. Then I fix the central part of the middle fat pad, or the central fat pad. This is the orbital rim is here. So transpositioning or redraping it over the orbital rim. One of the really important things is to check. This is inferior oblique, so I'd like to check if I need to check that the fat pad after transposition is not tethering the inferior oblique or not pulling it, because if it's pulling on it, it will cause double vision after surgery, and patients will hate you for this. So you need to make that as free, and you can see the transposed fat all the way here. Now I'm going to show you a video how you do the lifting the orbital malar ligament. So this one is only lower lid blepharoplasty, so I take it as high as possible. This is the lateral orbital rim, and this is the Whitney tubercle, so just like half a centimeter lateral to orbital Whitney tubercle. In the zygomatic bone, I take a bite in the periosteum. Then I go around the centimeter or so below the incision. I take the fat pad, the malar fat pad. I try to take a locking knot so it will heal, will hold the tissue well till it heals up. So this mainly in the malar fat pad, so it will shift the or lift the malar fat pad. What I do to decrease the length of the eyelid, because it's really important rejuvenating things to do, I take a bite at the nearby the Whitney tubercle at the periosteum. Then after that, I take what used to be the location of the origin of orbicularis muscle nearby the junction of the orbital rim inferior lateral. Like a bite, this is the lateral orbital rim, and this is the inferior orbital rim. What used to be attached to it before freeing it, I take a bite on it, throw it. This one will lift the attachment of orbicularis to the orbital rim higher. At the same time, this is the attachment of the orbicularis to the orbital rim, so I ask my assistant to lift it up. And tie it to the orbital rim laterally here. Normally it's under tension, so I like the assistant to hold the knot so it's doesn't slip. Just 1 minute, we'll finish. Yeah, you see here what I want to see. You see the orbicularis now is higher than its original origin, and this one will shorten the lower eyelid for you. Come on, Dr. Aman. Yeah, this is another good thing that you remind you to. When I suture the skin, I suture from lateral to medial. That will help in decreasing the chance for puckering. And plus, when you take your bite in the malar ligament or malar fat pad, try not to take it deep. Don't take it superficial. If you take it superficial, there will be puckering. But if you take it deep, you will not have it. And if you take it and still there is puckering, you can dissect between the skin and the tissue that you are taking bite of. But really, I found it really helpful for me to start suturing the transcutaneous incision from lateral to medial. it helped a lot to smoothen the lateral part of it. I used to do it from medial to lateral, but when I changed from lateral to medial, it really made a huge change. I know it's a small thing, but really it makes a huge change. Yeah, I used to do that, but when I shifted to this procedure, the result became way better. Because what happened, the attachment of the orbicularis was here. When you make it higher, the lid will be shorter, and by that time it will go a little bit down. So you don't need to go to suture to different places, because if you do that, will not achieve the highest level that you want to achieve. And most of patients, the higher you make it is better. Yeah, and also it will go with time. So I found this one is really more helpful in achieving the goal of the patient. Welcome anytime. We always learn from you. Thank you. So in conclusion, understanding expectations is really the most important things you need to do with the people coming for cosmetic procedure. Non-surgical options should be discussed and explored before going to surgical procedure and solutions, and always give the patient the pros and cons from surgical or non-surgical option. Understanding the anatomy and proper surgical techniques are important for successful outcome, and preserving tissue as much as possible is really important. And complication prevention is way better than managing it. Thank you so much. دكتورة هيلة. I can repeat if they don't hear. Thank you. I show only the best, by the way. Thank you so much. That's really something a lot of time is missed. So.
With regard to the lower limb, I tend to ask the patient to open their mouth and look out before I remove skin.
Yeah, this is really an excellent technique. Some people, they do bench technique. I usually eyeball it because after doing like 100 of it, you know what's really amount. But for a starter, it's good to bench technique or what Dr. Hale is mentioning. But after you do good number, you can excise.
Lower lid.
Yeah, for the lower lid.
But the thing that I've noticed that people coming from one of the common complications is, the hooding, because people don't remove enough skin laterally. And I see quite a lot of these coming through. One complication of attaching the orbicularis to the rim is when they chew, they might feel a pull.
True.
Have you ever had this complaint?
Unfortunately, not yet. Fortunately, thank you.
I'm surprised that you do quite a lot of young patients too.
Most of them are young, actually. That's why this is what I start with, because I get a lot of referral from dermatology. And ophthalmologists, they don't refer because they're waiting for really massive dermatochalasis to refer, unless young people are interested in this.
Since most of the audience, Dr. Haibani, I'll come back to you, Tariq, are residents and trainees and general ophthalmologists. Maybe not a lot of us are doing cosmetic surgeries. Will you please touch on the marking? Your way of marking both upper lid and lower lid blepharoplasty, because I usually try to stress on that point for residents to learn during my procedures. And is there a fixed rule that you use, like 10-10, or what's your preferred mechanism for us to? Can we dim the light again, please?
Yeah. Normally, for upper lid blepharoplasty, you need to start with the lid crease. Normally, I ask the patient to open their eyes, but not full, around 45 degrees. So I identify the lid crease. Then you mark the lid crease from all the way medial. Usually, I start marking the lid crease from the punctum, so it's corresponding to the punctum, not from the punctum, but corresponding to the punctum. From here, then I all the way laterally to the lateral canthal tendon, or the lateral ligament, tendon, yes, corresponding, not reaching it, till you reach the level of it. Then after that, you go lateral to prevent what Dr. Ahela nicely pointed out to the lateral holding. Also medially, when I start here from area point corresponding to the punctum, and also I move it medially a little bit, so I will not having extra skin medially. Then after that, you mark the skin. Normally what I do, for example, for a starter, I like to keep around, you mark the junction between the skin of the eyelid and the brow skin. And here is, you see the junction here. As a starter, maybe you start 1 centimeter. After you developed your experience, you know the muscle tones and other things, you can go a little bit lower. But for a start, it's good to make it at least 10 millimeter. And also you can gauge this amount based on amount in the pretarsal skin, because skin crease is not the same, the height for people. People with higher lid crease, you can move more skin here. People with lower lid crease, you can remove higher there. So you need to balance it. For lower lid blepharoplasty, we start again from the area corresponding to the punctum and the lower lid. And you go all the way to the lateral canthal. Then after that, you extend it till you reach the orbital rim. Some people, they stop before that, but I like to extend it till you reach the orbital rim. Then after that, you marked with either with the pinch technique, where you take forceps and pinch, or what like Dr. Hale just pointed. You mark, then you ask the patient to open if the skin is moving a lot or not, and based on that, you can judge.
Dr. Tibi. Now, these tips are important to prevent complications, especially lag of thalamus or ectropion in cases a lot of skin is removed. So the planning is very important for successful surgery. That's why I asked for Dr. Sahibani to stress in this. Dr.
Thank you, Dr. Adel, for this really excellent presentations, and I changed my mind about.
It's good to be attracting people with retina specialties.
Regarding to the issues of that in the ophthalmology, most of the patients coming to us when they have really problems, either with the lids or with the dermatochalasis when they are getting in the late age. I think the patients going for plastic, most of them, they are looking for cosmetic issues initially. So for that reason that you have these cases going, I believe maybe in our hospitals or maybe in your, even though in the King Saud University, most of the patients were not referred to them in the regular daily works of the because this is mostly like in plastic and elective procedures. So is there any nowadays that changing our indications so that can stress it in the ophthalmology practice, rather than just to go for just only the advanced stages?
The aim of this one is to rejuvenate. If a person is concerned about the way the eye looks like, for example, this is a good example. You can see this patient. Maybe, like if you work in a hospital, and a government hospital will not be concerned, but for cosmetic, it's really concerned for them. So it depends on people. People, for example, they are concerned about this. Other people are not concerned. So it depends on what the person concerned and person perception. And as I told you, many people, ophthalmologists, are not used to refer because they are used to look for diseases. They are not used to how can I make this person better? Yeah, aesthetic point of view. True.
Thank you, Prof. Adel, for this nice and interesting topic. I have two questions. The first question is, I know that many patients or many customers are coming to you and they're complaining of dark circles. And I think that dark circles can be caused either by excavation of the lower lid, it is deep. And the other thing is the skin is hyperpigmented. So do you have other options? For example, if this patient, I will do blepharoplasty. The other patient, for example, I will do other procedures, or for example, I will refer to dermatology because they will do other procedures. The second question is about the non-surgical blepharoplasty. I know I've heard about in some dermatology clinics, the plexer technique or the plasma surface to decrease the amount of wrinkled skin.
Yeah. For the first one, you need to examine regarding what the cause for it. Most of the times, if it's the skin only, you cannot do much. You can ask. There are a lot of creams in the market, but really doesn't help much. And there are also people talking about the oxytherapy, that they need multiple sessions, but even that one, you need to maintain it. That people need to do it so frequent. For me, it's not cost effective. What we can help with fillers, if they have really significant depression, you can do fillers for it. If a patient has significant amount of fat prolapsing, we can do blepharoplasty and tightening the skin with it, and do fat reposition. For the non-surgical blepharoplasty is still in the market, but really not taking lead because it's not causing really significant improvement comparing to the recurrence and other issues. There's still there are different modalities under trial, so no treatment that proved to be really effective yet.
Thank you very much, Prof. Sahibani. Now, I encounter few patients after Botox, they complain of diplopia. Is it a high percentage of those, or improperly done?
Most of the patients they count, or most of them, they develop ptosis. And mainly the ptosis happens, it was discussed with Dr. Hattan yesterday, from injecting in this area. Yeah. So if you inject it a little bit lower, it will, some of it will go to the levator muscle. The double fission depends. Was it for cosmetic or for blepharospasm? Mainly double fission, we see it after blepharospasm if you are injecting close to the inferior oblique muscle. After cosmetic, it can happen, but it's really not common. The ptosis is the one more common.
Okay.
But
because
it can happen.
This was few even stays for a few months complaining of diplopia, and in fact the patient did not admit, or even so I just questioned her very superficially. But then I found no other cause. I said, did anything? Did you inject? And then she admitted after, in fact, the second visit, and in fact she was alone. The partner was not available, but then some of them, they will not disclose, or even on superficial questions they will not admit, and unless you dig on this.
This is even more problematic for people having permanent filler injection, and now it's abandoned. It's محرم الحين في الاستخدام. لكن we used to people non-medical. They take it in a bag and they go to home and also beauty shops and they inject permanent filler, and they especially females, if they didn't take discuss it with their husband or their family members, they try to deny it. And if you're not really asking about it, normally they don't tell you. And even they come specifically alone. They don't come with somebody else. And this is one of the indicators telling you, oh, you need to ask about this.
You know, in my career, I just saw maybe, I think, 3 people only with diplopia among like tens of thousands who are like getting injections. Dr. Sahibani, how many patients did you see?
I haven't. I see a lot of ptosis. But
the ptosis, yes, but I'm talking about diplopia.
Diplopia is it's not common. But interestingly, most of these are improving in a very short time because the muscle is so active, so it goes in a few weeks.
Yeah, in a couple of weeks.
But that's why the hair condition is not usual. It's not the usual.
Dr.
I just want to reply to Dr. Al-Amrou. I think more people are injecting the lower lid to get rid of wrinkles that you shouldn't inject for. And then they direct the needle toward the globe. And that's when they get diplopia. Yeah. And it's usually not done by us, the oculoplastic. It's done by general plastic surgeons.
Well, unfortunately, nowadays, a lot of people are injecting. You never know who's... Wallahi, any dermatologist. Sometimes they call themselves cosmologists, and they're just, you don't know what's the background or the.
They don't understand the anatomy. That's the problem. They do not understand the anatomy.
What they are looking for is the money. That's it.
They're not even physicians. So sometimes in a lot of times, as Dr. Shebani mentioned, in beauty shops, and you just they call themselves like a specialist or أخصائية تجميل.
And this problem is not only here in Saudi Arabia. If
Everywhere.
you go to the US, the beauty shops, what happened? They have medical coverage. So I know a good number of oculoplastic. They go to these beauty shops and they sign the prescriptions, and the beautician is the one doing it. So it's a global problem.
But we get the complications. So they don't go back to the beauty shop and they start saying that I have ptosis or diplopia. Dr. Salim?
Thank you very much for this presentation. Dr. Adi, can you touch on your technique in anesthesia? Do you use nerve blocks with infiltration or infiltration alone?
Most of these patients, I do them in my private clinic. What I do all patients under sedation, either upper or lower, but it depends. For the upper lid blepharoplasty alone, I start with the propofol, then I inject subcutaneous. I don't give block for the supraorbital nerve or others for upper blepharoplasty. For lower blepharoplasty, I do block for the inferior orbital, the infraorbital nerve. And also I do it with the propofol plus Brisidex to maintain the patient's sleep the whole procedure for Brisidex. And also Brisidex helps in hypotension. So the blood pressure will go down, so the bleeding will be less. If I'm doing both upper and lower, Brisidex the whole procedure. So I found this one helps the patient to go with ease along the procedure. Plus these sedations are very safe. So this is what I do.
I personally learned from Dr. Shebani giving sedation to my lower lid blepharoplasty patients. In the beginning, I was not using it, and then once I was operating, he came to the room and he said, dude, why you didn't give patient sedation? And then I started using it, and I really, really felt the difference, especially for lower lid stomach. So well, it's,
Doctor, yeah, what happened, the injection itself is painful. And, a person comes for cosmetic surgery. You want to put them in ease. Putting IV line and giving a propofol, it costs you 20 riyals. Well, people experience will be way more different than going injection. I'm going to give you example.
Why sedation for the long term, not the propofol?
No, lower lid is painful. So we need to make the patient relax the whole procedure. Upper lid, no, is way less pain. That's why I inject with the propofol just for 10 minutes. When I do ptosis for upper lid, ptosis surgery, especially lid resection, I do it without sedation. And I remember one patient, I did for him ptosis correction. Then I had to do some enhancement. He said, doctor, I'm not going to do it again. قلت له ليش؟ قال, I remember the needle stick. That's why I like to do more muellerectomy, because muellerectomy, I don't need the patient cooperation, so I do it under sedation. But this is not true for the government hospital, so there isn't, no. I do it in the minor room without sedation. Because, to do a sedation in the hospital is a big hassle. You need to get admission and pre-op anesthesia and others, while in private centers is way easier. That's why in the government we are not treating the people the way they are supposed to be treated. Yeah, that's why.
Excuse me, which cases you were talking about, Victoria? Are you?
Yeah. No, we do. I'm not gonna give.
What is the problem?
No, it's done by anesthetist, by the way, not
Anesthesiologist
me.
usually,
Yeah, anesthetist is doing it. So we have anesthetist with us. Yeah, not ophthalmologist. No. No, that's not in the minor treatment room.
Yeah, the toes. The lower lids are more painful and more lengthy. Longer procedure compared to the.
دكتور مسفر.
معليش أنا الأنوار والله ماني شايف.
دكتور مسفر.
دكتور صالح تفضل. Interesting.
What kind of injection, Dr. Saleh? Is cosmetic or blepharospasm? Cosmetic. You know, propofol is widely common use all over the world. Even if you go to any clinic in US, Europe, now it's becoming popular because it's a short acting. And when you stop it, patient after 5 minutes wake up. That's why the people like it more. It's not as strong as it's not causing respiratory suppression as other agents. That's why the people like it more.
The main thing is to assure the airway because of just the relaxation they can swallow the tongue. But other than this, it is very short acting. And when quite few patients, very few patients, they are so afraid of the needle sticks, even for my intravitreal injections. Few patients, they ask, I don't want to feel, or for local, when we are doing for local. But in our routine is to do it and let the anesthetist do it.
Should be done by anesthetist.
Yeah.
This should be clear. Huh? Yeah. Okay.
Any other questions? Thank you very much, Dr. Sahibani. That was really nice and good. Thank you very much.
Thank you, everybody.
حاول تخليها بسيطة ايزي عشان ما حسيت لا وغير كذا ما حسيت بيصير في وقت في أسئلة والبراو is another topic على طول mainly to this area lateral exercise that's very good.
Congratulations.
Oh,
very nice.
Thank you for your attendance. Thank you.
I would like to ask you, for the mid phase, do you use Supramid? Because I use nylon.
Normally I use Vice.
Right?
Yeah, because it takes for yeah, for I mean after 6 weeks.
I use nylon because I am afraid about the but I used to do mid phase.
Well, actually, I typically inject steroid. Because edema will help with the edema and also to help with the granuloma. So I inject steroid typically, especially for the transcutaneous. I inject steroid.
Very nice. I think steroids very nice idea, and also 5-fluorescent.
Yeah. 5-FU I use it if there is a problem, like lid retraction or something.
It's not so strong.
Yeah. But the problem in our clinic, 5-FU is quite expensive. Steroid is very cheap. That's why private money counts.
Doctor, I would like to see the university. I've never been there.
Welcome anytime. See what's your best sign. Just give it to me.
Okay, maybe I go to the place. Can we start? Can we start the quiz? Can we have the resident to the front, please? Can I have the resident to the front? Front rows. Ladies, come forward. Assalamu alaikum. Are you ready to start? Okay, first question. Look at this patient. She's a healthy 4-year-old Saudi girl. Presented to us with the parent noticed that one of her eyes, they look different, and the right eye looks smaller. For the past 3 weeks. There was no associated pain, no redness, no other problems. First question. Okay. Lights off. Okay. First question, explain what you see. Just write down what you see. What are the findings that you can see in this patient? Question number 2, what is your differential diagnosis? Question number 3, what is the most likely diagnosis of the list that you've put? Question 4, what are the diagnostic tests or radiological tests that you will request the parent to have for this patient? Yes. This is question number 1. So I cannot answer it, because this is one of the requested questions. Okay? Look, what do you see? The 2 eyes are not the same. Is it proptotic? Is it ptotic? Is it swollen? Is what? Once you're ready to move to case 2, we will. Just let me know. I need the differential diagnosis, I need the most likely diagnosis, and I need the diagnostic test that you will do for this patient to help you to reach to your diagnosis. No discussions. This is only 3 weeks. Noted that this appearance is only 3 weeks. She is 4 years old. She wasn't born like this. She did not have fever. She did not have any other signs or symptoms. Can we move to case 2? Yes? No? Yes? Okay, good. Case number 2. This is a 69-year-old male. He's diabetic for the past 5 years. He came to the clinic complaining of drooping of the left eye, of the eyelid on the left side, as well as double vision at the same time for the same period of time. Question. There are other photos that I'll show you. This is his photos. You have tried to examine the eye, so you lifted the upper lid. This is what you see. Patient in primary position, looking right, looking left, looking up, looking down. Okay? So, first question, explain what you see. What is your differential diagnosis? You went ahead and did a CT of the patient, MRI for the patient. This is what you see. This is your finding. So what is the MRI, the finding that you see in this MRI? And how do you link this to the clinical findings? Last question on this patient is, what is your differential? I cannot go back. I want to go back. The last question is, why is this case not myasthenia gravis? Why is this not a myasthenia gravis patient? What is your differential? So explain what you see. This is the first question. What is your differential? That's number 2. What is your MRI finding? That's number 3. The last question is, why is this not myasthenia gravis patient? Diagnosis. Go back to the history. Sure. Vision is unchanged, but he has double vision, diplopia. He has double vision. No. He came to the clinic with double vision and drooping of the upper lid. Okay? Can we move? Number 3. This is a 3-year-old girl presented to you with redness in the left eye, which has been progressing, and now it's involving the other eye as well for the past 3 to 4 days, and at the same time with no eye discharge or redness. Okay? Question is, what is the clinical findings that you can see in the photo? Just describe what you see. Describe what you see. Her eyes. Number 2, what are the questions in the history that you want to ask that might help you to get to the diagnosis? what would you ask the parents? So that you can get the diagnosis without any test, without any lab tests. Relevance points in the history. Number 3 is, what is your differential diagnosis? Just put a couple of differentials or 3 differentials if you can. The last question on this one is, what are the investigations that you will do? Yes. Yes. What is your differential? What are the investigations that you will do for this patient to get to the diagnosis? Can we move? Case number 4. This is an 8-year-old boy who was referred from his family physician because he had this head position as seen since birth. His visual acuity is 20/20 in both eyes. The question is, what is this head position that you see? Just write it. What is this head position? Question number 2 is, why would a patient, any patient, whether an adult or a child, adopt a head position of any type? Why? This is one of the positions, of the 9 positions of gaze that you saw while examining the patient. This is the same patient. What do you see? Describe this. Describe this, the eye motility that you see now, the limitation or whatever you see in this position, in this photo. Describe it. You see limitation, you see overaction, whatever you see. Just write it down. Yeah. Yeah, he's looking this way. And up. Yes. He's looking left and up. You see this one? This is the eye which is in proper position. So what is your diagnosis? Okay, last case. This is a 16-year-old patient. Actually, he's not 11. He's a 16-year-old patient presented to your clinic because his parent noted that he has an abnormal eye movements. and he also have a face turn. Otherwise, he's healthy with no systemic problems. So describe what you see in the photo. This is question number 1. Describe what you see in the photo. This is the patient in primary position. Patient looking right, looking left. Again, same thing, looking left. So what is your finding? Second question, it's what is your differential diagnosis for this patient, this appearance? And what is the most likely diagnosis? What is your differential and what is your most likely diagnosis? Whatever you can, just go ahead and list them. The last question is, what is the surgical indication, or when would you go and do surgery for this patient? When would you tell the parent that your child needs surgery? What is your finding? What is your differential? And what is your most likely diagnosis? That's number 3. And what are the surgical indications, or when would you go ahead and do surgery for this patient? Whoever is ready with his answer, just put on your answer sheet on the table here, please, before we go for the discussion. What is the surgical indication? Meaning, when would you do surgery for this patient? Repeat. Okay, sure. نسوي الدسكشن الحين ولا بعدين؟ طب ما قلت لهم حطوها هنا. Nobody leaves the room, please. Nobody leaves the room. Put your paper and sit down. إيه بس they will not leave. We will start the discussion right away. يسلموا الورق حطوها هنا وخلاص. بعدين repeat the question. Okay. A healthy 4-year-old female presented with a history that her eyes do not look the same for the past 3 weeks. She has no associated ocular pain or redness or any other symptoms. Question 1, explain what you see. 2, what is your differential diagnosis? 3, what is your most likely diagnosis? 4, what are the diagnostic tests that you will do to get to the diagnosis? Two, 69-year-old male, diabetic, for 5 years, presented with drooping of the upper eyelid and diplopia for 3 weeks. This is how he presented, and this is what you see when you open the eyes. Primary position, looking right, left, up, down. Explain what you see. This is the first question. What is your differential diagnosis? What is the MRI finding that you see in this picture? And why is this not myasthenia gravis patient? Three years old girl presented with redness in the left eye. This is now progressing to involve the other eye for 3 or 4 days. Question, what are the clinical findings that you see? What are the relevant points in the history that you would want to ask the family about to get to the diagnosis? It will help you in the diagnosis. What is your differential diagnosis? And what are the lab tests that you will do? For case number 4, an 8-year-old male sent to you from his family physician because he's adopting this head position since birth. However, he has no problem with vision. His vision is 20/20, both eyes. What is the name of this head position? Nobody leaves the room. Okay. What is this head position? The second question is, why would any person, whether an adult or a child, adopt or take a head position? Okay. This is head finding, one of the positions. You saw this eye motility problem. What is your diagnosis and differential diagnosis? 5, this is a patient, 16-year-old, presented to the clinic because of abnormal eye movements and a face turn. Otherwise, he's a healthy patient. Question is, what is the finding that you see in this patient? Primary position and 3 positions of gaze. What is your differential diagnosis? Most likely diagnosis. What are the surgical indications for this patient? Okay. So let's have your sheets and we'll discuss the cases now. What are the surgical indications? Surgical indications. Case number 4, differential. What is your differential? Can I have an R3 or an R4? Who would go for case number 1, please? Case number 1. Who would want to be on the hot seat? Yeah. Who wants to be on the hot seat for discussing case 1? تعالي يا دكتور. Okay. What's your name, doctor?
I am Ahmed Al-Amir, R3.
R3. R3 on the hot seat. طيب. So, case number 1. Explain what you see, doctor.
I can see right eye ptosis.
Okay, so ptosis in the right upper
In the
lid. Okay.
Yeah.
What is your differential diagnosis?
Congenital myogenic ptosis, which is less likely.
Okay.
We can-
It's unlikely, as you said.
It is only 3 weeks duration.
It's 3
in
weeks.
a 4-year-old child.
Okay.
Mechanical ptosis,
Mechanical ptosis, okay.
third nerve palsy, Horner syndrome.
Okay, why is it not third nerve palsy?
We should check for the motility first of all.
Because he has no abnormal motility, patient did not complain of diplopia.
Okay.
So you cannot have a third nerve, so I will take this out of your differential. Okay?
We should check the pupil for the Horner syndrome.
Okay, pupils are normal.
Myasthenia in
So this will come under what category?
neurogenic.
Neurogenic.
Yes.
So we have like 4 or 5 differentials here. That's good enough. So what is your most likely diagnosis? What do you think?
I'm thinking about mechanical ptosis or myasthenia.
Myasthenia
gravis.
gravis. Okay. How would you confirm it's myasthenia gravis?
By history, asking if it's a variable.
Okay, we know the history. This is done, finished.
Then eyes test
The eyes test, exactly.
and fatigability test. You ask the patient to look up for like 1
Okay.
minute.
Give me a lab test.
Acetylcholine receptor antibody.
Acetylcholine receptor antibody,
and
yes.
anti-musk antibody.
Great.
Also, you should do a CT scan of the chest to rule out thymomas.
Great, thank you. Go back. Can I have someone for case 2? Yep. Mechanical. It's unlikely for Rabido to present with ptosis. But this is one of the tests that you will do. You will do an MRI of the thymus and the chest, and I will go for also orbits, MRI orbits. Okay, how would you confirm that? Look at the child here, she's trying to move the lid, the mouth, you noticed? This is the picture. That's why you have this picture. She's trying to move the mouth, and you see the lid? With Marcus gun, what's going to happen? It will widen up. It did not. It stays the same. So see, it stays the same. So it cannot be Marcus gun. Okay? Case number 2. Who wants to be on the hot seat? I need an R3 or R4. Come here, please, doctor. Introduce yourself.
Abdurrahman Zaid, R4.
Okay. 69-year-old male, diabetic for 5 years, presented to you with droopy upper lid and diplopia for the same period. Okay, explain what you see.
So in this first photo, I see a external photo of the eye showing complete ptosis of the left eye. So you cannot assess the position of the eye or the motility in this photo.
So what do you want to do?
I would like to elevate, open the lid.
Okay.
Now I see complete external ophthalmoplegia, including the complete limitation of abduction as well of the left eye, with the dilated pupil in the left eye as well. So this gives me the hint that the patient have complete external and internal third nerve palsy plus sixth nerve palsy in the left side.
What is external and internal third nerve palsy?
External, I mean only the muscle, meaning only external ophthalmoplegia. The internal because of the pupil It looks slightly dilated compared to the other eye.
Yeah, but we don't usually call it external and internal. Partial or complete third nerve palsy. Okay? طيب. What is your differential diagnosis?
I need to think of, first of all, neoplastic cause,
Okay.
a compressive lesion, cavernous sinus lesion, Hunt syndrome, ischemic vasculopathy since he's old age and diabetic. And I need, first of all, to do imaging. Since he have...
Imaging?
So this is an MRI photo showing, it looks like cavernous sinus thrombosis.
Cavernous sinus what?
Thrombosis. And or compressive lesion along the
It's a mass.
orbital apex.
That's a mass in the cavernous sinus.
Yeah. Compressive
Okay.
lesion in the cavernous sinus.
Okay, so your diagnosis is
Third,
complete.
Complete third and sixth cranial palsy.
Second what? Sixth nerve palsy?
Yeah, yes.
Okay, let me see if we have restriction here of. Yes, okay. Actually, there is slight movement, but it's not complete. Like it's not go all the way, it doesn't go all the way up, but it's not a complete pulse. It's not a complete third nerve, sixth nerve. Okay, so this is cavernous sinus mass causing a third and partial sixth. Why is this not myasthenia gravis patient?
Because of pupil, first of all, pupil involvement, myasthenia gravis will not affect the pupil.
Okay.
And second of all, the presence of the mass in the MRI.
Okay, great. Thank you. Another one on the hot seat. I can have an R2. Female. Female خوافين ما هم راضين يطلعوا. خوافين. حنان. اطلعي. R2, yeah. R2. This is the case for R2. Introduce yourself.
So I'm Iman Sharif, R2 resident in KSU.
Okay, 3-year-old girl presented with redness in the left eye that now it's going to the other eye for 3 days.
So there is right upper lid, right lower lid swelling and erythema, with left upper and lower lid erythema and swelling.
Okay.
So this is the finding.
What are the relevant points in the history that could help you in the diagnosis?
First of all, history of recent upper respiratory tract infection, any nasal discharge, any cough, any insect bite, any trauma.
Any
plus,
fever?
Fever, yeah, exactly.
Any fever.
Yeah.
And also I mentioned here that she has lethargy.
Yeah, which indicates that she's sick.
Indicating that she's sick. What is your differential?
So orbital cellulitis.
Patient orbital cellulitis. What type of cellulitis?
Orbital versus preceptal. Here it's more likely to be orbital since she's having fever, involvement of the other side as well.
Okay, how would you differentiate an orbital from preceptal?
We need to do CT imaging to
No,
confirm
before
the
that.
diagnosis.
Before that.
Motility on examination.
Motility
check for
and?
Proptosis, check the optic nerve function.
And?
Vision, but she's 3 years old.
So you said motility and?
Motility, proptosis, and...
you can have in both proptosis.
And optic nerve function.
What about the pupil?
Yeah, pupillary involvement. I mean APD, any optic nerve had edema or hyperemia.
Okay, great. So give me, so you put preceptal cellulitis as your final diagnosis, but I need a differential.
Preceptal versus orbital or postseptal involvement.
Okay, others?
Maybe.
Any volunteers? Yes?
Allergic, yeah, allergic.
Viral conjunctivitis? Not with this picture, okay? So metastatic tumors in general, and malignant tumors, metastatic or original. For example, she had also upper respiratory infection, so maybe this could be a lymphangioma. Okay. An inflammatory pseudotumor. Okay. What are the investigations? Now, this is the last question.
Yeah, so we will start with baseline investigation, CBC with differential ESR, C-reactive protein, blood culture, nasal swab, conjunctival swab, and CT.
CT of orbit and?
Orbit and sinuses.
And sinuses. Okay, great. Thank you. Case number 4. Someone on the hot seat. Someone on the hot seat. I want, yalla. Introduce yourself.
Abdelmajid Al-Fakhri, R2.
R2. We have a brave R2. Okay, 8-year-old referred from his family because they noted this head position. Visual acuity is 20/20 and it's been like this since birth. So the first question, what is this head position?
A right head tilt.
That's a right head tilt with a chin up?
Not clear for me, chin up.
A little bit of a chin up position.
Maybe.
The second question is, why would someone take a head posture?
To avoid abnormal vision, like double vision.
Okay.
So to avoid it, they use this. Or if there is inability to move the muscle, like in sixth nerve palsy.
Okay. Would a patient with nystagmus take a head position?
Yes, to achieve the null point.
To achieve a null point. And would a patient with restrictive or paralytic strabismus take a head position? Why?
To avoid the area of double vision.
Okay, so these are all reasons why someone would take a head position.
Yes.
Okay.
Also, bilateral ptosis, and patient might have a chin up position.
Okay.
To avoid
would a patient with a problem in the neck muscle take a head position?
Yes.
Yes. So you have to put it, because everyone with a head position will come to you, to come to an ophthalmologist. Almost everyone. The first thing they will think about is he has an eye problem. So you have to be able to differentiate between this is your case or this is someone else's headache. Okay? Okay, what is this position that you see?
So I see here a limitation of elevation on adduction.
In the right eye?
In the right eye.
Okay.
Yes. So
what is your diagnosis and differential?
So this could be inferior oblique palsy.
In the right eye?
In the right eye.
Oh, this is one of the differential.
Yes.
Okay. Give me another differential.
Could be superior oblique overaction, or.
Okay. This is not very uncommon.
Brown.
This is Brown's. This is exactly the situation. This is Brown. And the other differential is this could be a right double elevator palsy. Do we know what is a double elevator?
Yes.
Okay, so in this case, how would you rule it out? Right gaze and looking up. Okay, great. Do you have another question? Yes, and one last question. Okay, no more questions on this one. Last case.
Thank you.
Thank you, doctor. One more volunteer on the hot seat for the last case. Last case. Ladies. R1, yalla. Where is my resident? Where is my resident? Rehab? Because we just had this case this morning. Okay. 11-year-old presented to the clinic because of this head position and abnormal face turn and abnormal eye movements.
My name is Reem Al-Ahmadi. I'm an R1.
Okay.
This patient has limitation of a deduction of the right eye and narrowing of the palpebral fissure of the right eye in a left gaze.
A left gaze, okay. These are the findings that you see. What else do you see here in this eye? What do you call this one?
Upshoot.
Upshoot or the leash phenomena?
Yeah, leash phenomena.
Okay. Okay, this is the first question. What is your differential?
My first differential is Duane syndrome.
In which eye?
In the right eye.
Type what?
Type 2.
Type 2 right eye.
Yeah.
Give me one more differential.
Could be a contracture of the lateral rectus.
What?
Contracture of the lateral rectus.
Secondary to what?
Prolonged congenital exotropia.
Congenital fibrosis. Congenital fibrosis of the extraocular muscles. This can give you very abnormal eye movements. Okay? And one of you guys mentioned before that Marcus Gunn, jaw winking, on one of our slides. This also can present with an upshoot in some patients. Okay? The other question is, so what is your diagnosis?
Duane syndrome.
Duane
type 2 of the right eye.
Okay. What are the surgical indications?
Abnormal head posture.
Okay, so you would go for in this patient?
Yes.
Okay, and the other indications?
Deviation of the eye in primary gaze.
Which this patient has?
Yes.
And?
Leash phenomena.
The leash phenomena. Thank you.
You're welcome.
Actually, these are all board questions. These are all board questions, so I gave it to you because I know your oral is coming soon. So these were all oral questions, but you will not get any in your oral from these, but because these are board questions, not King Saud questions. Okay, thank you.
السلام عليكم. Can we start يا شباب؟ Can you call everybody else? نبدأ. Assalamu alaikum. Good afternoon. I'm going to start the glaucoma conference today a little bit differently than the usual imaging. We had those last year. So I'm going to talk about something that's much more common, something that we usually see, especially after surgery. So we're going to talk about post-operative complication. I don't want to show surgery or intraoperative complication. That's a discussion for another time. But we can talk about the post-operative complication today. And of course, it's a discussion-based conference, so I'm going to need your participation. So basically, you know, all filtration surgery, specifically trabeculectomy, is a commonly used procedure, mostly commonly used procedure. The basic idea is to create a fistula between the anterior chamber and the subconjunctival space. It has been modified throughout the years, and usually it's safe, but it still has some risk and carries some risk. So not working. Maybe I'll show you. So this is a video courtesy of Dr. Samir Ahmed, shows the basic steps of the trabeculectomy. The basic steps or everything is almost the same, but there is slight variation by each surgeon. Everyone has his own technique, has his own limit, but the basic steps or the basic principles is the same. So you start by periotomy, followed by cautery, scleral flap creation, sclerostomy with a punch, then after that an iridotomy, then you close the wound in a watertight fashion. I'm going to speed up here. You're creating the flap here, and some surgeons prefer a pre-placed suture to control the anterior chamber. And we create the fistula with the Killy punch, followed by a closure of the flap, creation of iridotomy, then closure of the flap, then closing the conjunctiva. So many ways, so many techniques to close the conjunctiva. The basic principle is the same. You have to make it watertight. So, in the next day, first day post-op, what do you look for? I'm going to talk about the abnormality here today, but let's first know what is normal. What does the normal look like? So, in the next day, what do you look for? What do you examine in the patient? Anyone? Okay. You want to see if the AC is deep or not? Okay. 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 جميل. لو تستخدم المايك يكون أحسن عشان أسمع. طيب. Usually this is what we look for. As you mentioned, anterior chamber is deep, controlled pressure. A good filtering blip that is not very high, not very low, just good enough, like low blip with a microcyst, diffuse filtration. This is the ideal blip. And of course, a watertight sealed wound, conjunctival wound. So you can arrange the post-operative complication however you like. You can arrange it with either with flat chamber versus deep chamber, then with high IOP versus low IOP. However you like to arrange it, you arrange it. This is basically the early post-operative complication that you could face after glaucoma surgery. So I'm going to start with the deep anterior chamber cases. Some of you might want to take the mic and answer me on this. يلا شباب. So this is 4 or 5 days post-op. Anterior chamber is deep. What else?
Here I cannot see the blip. I think it's not well formed.
Okay, that's right.
Yeah, so I need to check if it's leaking or if it's.
Okay.
Yes.
It's not leaking. Very tight.
So I want to see the IOP of the patient.
It's high, really high. 30, 35.
So this could be a tight suture.
Okay.
So we can we need to see the angle also. The angle of the patient. If there is.
That's my whole point. We need to do gonioscopy. Do gonioscopy first to see. This is basically a deep anterior chamber with blip is failing here. So you want to know if the cause of the failure is either internally or externally. How do you know that? If you do gonioscopy. Sometimes it's closed internally by what?
By the iris tissue.
Okay,
or,
iris tissue.
Part of the vitreous leak.
Vitreous, fibrin, blood.
Fibrinous reaction.
Okay.
Of blood.
Can be blocked by any of those. And what is the treatment? Let's say it's blocked by blood. What do you do here?
You need to do revision.
blood from inside. Just observation.
You can start by observation.
Just observation. Medication will usually do the job. Blood will go away. Same thing with fibrin. You can use TPA if it doesn't go away, but yeah, it's basically medical treatment. You can observe for a while. If it's vitreous, you can do a YAG vitreolysis to cut this vitreous strand. And if it's iris, well, you have two ways. If it's very early on, you can do you can put some pilocarpine, or you can use even mycol within the 24 hours, 24 hours, 48 hours. You can use mycol and the iris will retract. But if it's long enough, sometimes mechanical retraction of the iris will help. Mechanical pulling of the iris will help usually. Okay. Now, if it's internally okay, then it means it must be closed externally. So there is two reasons for that. One is tight suture. The other one is conjunctival scarring or scleral bed scarring. So in the case of conjunctival scarring, in the case of tight suture,
you can consider suture lysis.
Yeah, you can do suture lysis, or if it's early on, first day, you can do ocular massage, for example, create the bleb, wait a little while for 1 week or so, then you can do the suture lysis. Okay?
Okay.
If it's fibrosis, what do you think we should do here? If it's conjunctival fibrosis or scleral bed fibrosis?
We can try
you can see here that. Yeah.
We can try needling.
Okay. You can try needling to open up the flap. Yes. So you go up to the anterior chamber.
Yes.
My point is you try to open up the scleral bed. Okay. Sometimes you do mitomycin, sometimes you don't want to do mitomycin, that's fine, but preferably you do mitomycin is better to help decrease the fibrosis.
With the needling, you can use mitomycin again.
Mitomycin first, then you do the needling. Okay. Ocular massage. You basically do it behind the patient looks down. You can, with a Q-tip, wax or whatever you have in the clinic, you press on the sides of the flap, and it will rise up. Usually it will rise up. Yeah, it will balloon up for you. Okay. What else? So this is the patient after suture lysis. You can see the suture is cut in here and in here. A little bit, the flap is raised a little bit in the nasal side. So this is the next one, next case. Again, with a deep anterior chamber. The only difference here is 4 to 6 weeks post-op. So what do you think? Yep. أحد ياخذ المايك. إبراهيم أعطنا.
Encapsulated bleb.
Okay.
With ring of steel around it.
Okay. Perfect. So basically here, when you do examination, especially gonioscopy, you will find the sclerostomy is patent. Nothing is blocking the sclerostomy. It's basically a tenon cyst capsulation. Takes from 2 weeks to 8 weeks, 2 weeks to 2 months to form. And the difference between here and the previous case is that you can here treat by observation or medically by medication. You don't have to go immediately for suture lysis or needling. You can wait a little while. That's the major difference. And you can see here. So this is how you differentiate between both of them, failing bleb and tenon cyst. The tenon cyst, you have a high bleb, and the failing bleb is very low, almost flat. Both have high IUP. In the failing bleb, you'll have a heavy vascularization. That's most of the time, heavy vascularization. And I think using anti-VEGF could help. I don't know if Dr. Samir or Dr. can help us with this. Dr. Samir, if you have an idea. Yeah. You can use anti-VEGF to decrease the vascularization, especially in cases like neovascular or something. It helps when you use 1 milligram of anti-VEGF subconjunctivally. So, again, the onset, failing blips start early on, and tenon cyst takes a while. And the most important thing is that when you do gonioscopy, you'll see the difference most of the time. So there are some risk factors for this, for failing blip especially. And the most important thing is previous failure of history of failure. For example, patient did trap in the other eye or in the same eye. Usually this trap is doomed to fail. Young age is also one of them, scarred conch, inflammation intraocular, and also neovascular changes and neovascular diseases. Okay, let's move on to the next category, shallow anterior chamber. Can someone else help me? So this is a patient immediately, yes, 1 day post-op, trabeculectomy, as you can see here.
Yes, this is external photo showing almost flat AC.
Okay.
I want to check the IOP.
IOP is really low, very low.
And to do sidle test.
Okay. So. Okay.
So this is a blip leak.
Mm-hmm.
For how long the surgery, you said?
Yesterday.
Okay. So this is early blip leak. You will, as it is early.
What is your management?
Yeah, you can hold the steroid.
Okay.
Or decrease it at least.
Okay.
You can use bandage contact lens.
Mm-hmm.
Or pressure patch, or gentamicin to irritate the blip.
Okay. I would do that, yes, but if the AC is still deep, if the AC is really shallow like this, almost touching, and the flap and the leak is huge, I would resuture immediately. I don't wait for this. This is resuturing. If the AC is still maintained, yeah, sure, I can wait and do whatever you said is right. You know, decrease the Brit 40, add gentamicin, enhance the inflammation more. You can do scleral patch, scleral bandage contact lens, or a light patch. All this will help, yes, if it's a micro leak and the AC is still deep. But if the AC is shallow like this, I would do resuturing because nothing will help here. So this is a chronic case, basically out of the subject a little bit. This patient is 3 years out of cataract, out of trabeculectomy. With this picture, what do you think? Okay. Mm-hmm. What are you afraid of here? What do you look for here? Okay. Yes. So the eye is quiet, yeah, but you're afraid of future infection, or so measuring for a leak is very important here, because most of these cases they have micro leak, and they are missed if you use the light fluorescein. You should use 2% fluorescein to not see it exactly. And this is leak, yes. So what would you do for this patient? This is a chronic case now. It's 3 years or 4 years. I'm sorry? Okay. Okay. Resuture. Suture what? Let's say blip revision. Blip revision, you can do either conjunctival advancement, yes, or even hatta amniotic membrane, whatever you have, you can do. The idea is to cover this leak and stop it. But yeah, you start here, conservative treatments, lubrication, antibiotic, wait, observe and see for a couple of weeks. As long as there is no infection, you can wait a little bit. If it's not improving, yeah, you can do autologous blood injection. It will help. Okay. So this is another case of shallow anterior chamber. Anyone else? Anybody? This side. Should I choose? Dr. Hana?
This is post-op or what?
Yes.
Day 1 or what?
Says yes. Day 1 post-op, trabeculectomy.
With shallow AC?
Very shallow AC, yes.
How much is the pressure?
It's very unreadable.
And I'll do sidle test.
Negative.
Check for me.
Negative.
Then we'll examine the bleb. Seems like it's not formed.
Actually, it is very formed. It's really high bleb. Oh,
Okay. Sorry. Okay, it's formed. We'll examine the fundus. Look for choroidals. Yeah, it looks like there is optic disc swelling, choroidal folds, and hypotenuse maculopathy.
Okay.
From the bleb, it seems like overfiltration.
Okay, yeah. Yes, if there is no leak, and check for leak many times. Take your time with checking with leaks. If it's not leaking, most likely it's overfiltration. How would you manage that overfiltration?
Overfiltration, we can do autologous blood injection to reduce it.
This is first day.
First day, we'll reduce the steroid. We'll increase the steroid.
Okay.
And we'll observe.
Okay, good. So basically it's observation. 90% of these cases will improve, AC will go back, everything will be fine. But if it doesn't, if it persists,
we can...
So you can use cycloplegic. The idea is to deepen the AC, try to deepen the AC forcefully with the cycloplegia, atropine or cyclopentolate, whatever you have. Okay? It will pull the lens iris diaphragm backward. This is what you want, to get the AC a little bit deeper. This will take times usually. It will improve. If it doesn't, you can... Yes, I'm sorry? Yes, you can do compression suture on it. You can over the conge. You can do compression suture. Or you can do resuturing of the flap itself, because the flap is really leaky. You can suture it. Go back, open it, open the conge and resuture the flap. Okay. Okay, this is another patient. Again, next day, post-op, shallow anterior chamber. Somebody else.
Okay, post-op day 1.
Yes.
This looks very shallow AC. What about the IOP?
IOP is high here.
High. So we have to examine there is pain.
Yes.
Fundus exam.
Sorry. What's messed up here? Low IOP here. Yeah, sorry.
So high or low IOP?
This is low IOP.
Yes. It is. It looks like cyclodiasis cleft.
Okay.
So we have.
How would you know that?
The sclera, the whitish. From the cornea.
Cyclodialysis cleft is a separation between the ciliary muscle and the scleral spur. So you can see basically the sclera through it, not like the angle recession.
Yes.
Okay.
It is not,
so
not
yes.
brownish.
Yeah.
So we have to give the patient cycloplegic.
Okay.
And observe the patient.
What is this?
This is the UPM show the fluid in the cleft.
So it shows basically separation between the ciliary body and the scleral spur.
Yes.
So this is how you can confirm it. Beside also gonioscopy, just to confirm your diagnosis. And what do you do for cyclodialysis cleft?
We'll give cycloplegic and increase the steroid. And if this is not improved, the patient after a while, we can do laser.
What do you call it? Gallic, yeah. Cyclopexy. Aragon laser cyclopexy. Or suture cyclopexy. Surgery. Okay. But usually they improve on itself, so you don't need to treat it. Usually it will close up with time, but watch out for high spikes of intraocular pressure after it. Okay. Now to more serious complication. Rahman? Yeah.
So this external photo showing the eye. The AC looks slightly shallow, but we need to examine the slit beam to make sure. From this what's the IOP of the patient?
Low IOP here also.
On this photo showing choroidal detachment, it's like serous choroidal detachment. I need to examine the blip, pull out any leak from it as a cause for this.
Find the cause for the, exactly. That's the main thing you do in choroidal detachment. So the eye has a hypotenuse. You're trying to find what's the cause for this hypotony. Okay.
If there was no leak, I would start the patient on steroid. If the patient have a huge blip as an oval filtration with no leak, I may consider to taper the steroid to induce some inflammation and increase this oval filtration. If the patient have a normal blip with this picture, I would give him just increase the steroid and give him cycloplegic.
Okay. What else you would do with the patient? What if it doesn't work?
I will not do any surgical intervention unless there is certain thing like kissing choroidal or lens corneal touch.
So the indication for surgical intervention is kissing choroid or
lens corneal touch.
Lens corneal touch. Okay. Okay. Perfect. So also you can give the patient steroid, oral steroid also. It will help also. And if it doesn't work, always drainage is the solution. Surgery is the solution. Okay. Depends on the symptoms. If the patient does not improve within 2 months, 3 months, I don't think he will improve. So maybe we can intervene, yes. But you can give him steroid orally for this time. 1 milligram per kg, for example. Okay. So this is an ultrasound. You can follow the patient up with the ultrasound photo of the fundus photo just to know how big is the choroid and follow it back. This is another case who had trabeculectomy 3 days or 4 days. He presented to you with severe pain to the ER.
This photo show shallow AC with almost iridocorneal touch. And you check the IOP of the patient.
Okay. High IOP.
High IOP.
25, 30, I'd say.
I will check the patency of the VI of the patient.
It is patent.
And I will do.
It's not clear, but it's clear. It is patent.
I'll do a fundus exam to rule out suprachoroidal. So this is a fundus photo showing a suprachoroidal hemorrhage, choroidal detachment, which looks like hemorrhagic suprachoroidal hemorrhage. So, but it is not kissing, and there is no lens corneal touch from the photo.
Almost,
so,
yes.
Yeah. So I would just closely observe the patient, give him cycloplegia and atropine. This piece can showing a kissing choroidal detachment.
I don't think it's kissing here. Here's the choroid.
So just observe this patient.
Yeah, I would observe this patient. It's the same thing, hemorrhagic choroidal detachment, suprachoroidal hemorrhage basically. So you observe him with medication, the same treatment here. So when to interfere here if the patient has suprachoroidal hemorrhage? You want to drain it. It's not improving, nothing goes away. When to interfere?
In cases of kissing suprachoroidal hemorrhage, or if there was a lens corneal touch, and usually you don't interfere early. You leave it for 1 week for the blood to liquefy.
Okay.
And then you do a sclerotomy, preferably inferiorly, to drain the suprachoroidal blood.
Okay. Yes. Perfect. Some of the risk factors for patient with suprachoroidal hemorrhage, you should consider it before you do surgery for the patient, especially high pre-op intraocular pressure. So decompression of the patient when you do trabeculectomy or whatever shouldn't be sudden. It should be gradual, or at least give the patient anti-glaucoma or IV anti-glaucoma before the surgery. Always work on an eye with a good pressure. To work on an eye on high pressure. So again, this is a case maybe a week or two after surgery with a pressure of 25 also. No pain, decreased vision. PI is patent. And this is it.
The case of aqueous misdirection.
Yes. Okay. So what's your treatment here?
First, I will start with the. If I'm not sure the BI is closed or not, I need to examine it again. I may do a BI again.
Okay.
If he have a patent BI, we'll start the medical treatment, which 50% of the patient respond on it. I'll start him in Brit 40 and cycloplegia in the form of atropine and anti-glaucoma, and reassess the patient.
Okay. And if he doesn't improve?
If he does not improve, the patient is pseudophakic. I would go for YAG vitreolysis. In case if he was aphakic and he had a large BI, I would do it through the BI itself.
So in the YAG vitreolysis, you go for the anterior hyaloid specifically. So it's a YAG hyaloidotomy.
YAG
specific.
hyaloidotomy, sorry.
Yes. You're trying to open the anterior hyaloid so the vitreous doesn't go, so the aqueous doesn't go back. It has an escape route anteriorly. Okay. Perfect. And if it doesn't work, you go for surgery. What kind of surgery?
I would do paraspinal vitrectomy and do anterior hyaloidectomy to disrupt the anterior hyaloid face, make sure to disrupt it to break the attack of aqueous misdirection.
Okay. So they call it IRIDU, zonular hyaloidectomy. Okay. To make a continuous opening between the anterior chamber and the vitreous. Okay. If the patient is phakic, you can also take the cataract out. It will help a lot. So you do phaco also as well with it. This is what is this, Abdurrahman? What is the test here?
This is a UBM.
Okay.
Showing anterior rotation of the iris diaphragm.
Yes, as you can see here. Yeah. Okay. Someone else now?
Yes.
Yes. So this could be early, could be late.
Yes.
Could happen anytime.
Yeah, and the IOB can be normal also.
Doesn't matter.
Yeah. Injected eye, and the blip seems pussy, filled with discharge. There is white secretion.
Okay.
This is
pus.
Yes. This is blepitis, but I have also to rule out endophthalmitis.
Okay.
I have to do fundus exam.
Sure.
Okay. AC reaction? Any AC reaction?
Yes, there is, yeah. Definitely. But it doesn't change your management. If you have a clear fundus, no vitritis,
Yeah.
good red reflex, this is only blepitis.
Yeah, I will manage with fortified antibiotics.
Like what?
Vanco and
Mhm.
Sifta,
Mhm.
alternating.
Okay.
Give the patient cyclo, and I will take a swab for.
Perfect. Okay. When do you see the patient? You want also to admit the patient as well?
Yes.
When do you want to see the patient?
Q6.
I'm sorry?
Q6.
Okay. You can see him every 4 hours to 6 hours in the first day at least. You can also do P-scan, not for diagnosis, for follow-up. Okay? As well as the fundus exam and the vision as well. Vision here is really important. Okay? Also, it helps also to look for the sources of this infection. Usually those patients have blip leak most of the time. So if you stain them You will have lip leak most of the time, but sometimes they don't. What is the organism here involving it?
Streptococcus
Okay.
epidermidis and viridians.
So let's change it to a little bit. What if this is the fundus you found? In the same patient, if you found this fundus.
This one, there is vitritis.
Mm-hmm.
And this is endophthalmitis. as
Okay.
well. I will also consider.
Would you do the same? Would you change something?
No, I will give intravitreal.
Okay.
And Barsplan vitrectomy.
Okay. Why the intravitreal? If you're doing pars plana, you're going to take it out. What's the point? After surgery, you mean? Maybe, yeah, sure, I can do that. But the main treatment here is surgery. Vitreous slab, sure. But I mean, the treatment here is what? Vitrectomy. Regardless of the vision, regardless of how early, how late, you always do vitrectomy here. And the reason is because you have the organism is virulent, Streptococcus. Okay? I might consider injection, yes, especially if he had hypopin, especially if he's zoodophilic. Even if the fundus is okay, I might inject as a prophylactic. Yes, I can do. You should do that, actually. It will help to prevent progression to endophthalmitis. Yes, but you can have blebitis with hypopin and no no endophthalmitis. Yeah, you can have that. Yes. Any questions? Follow. Mm-hmm. Can do that, yeah, sure. But if it helps or not, I don't think it will help you very much. In the beginning, you should observe them. Usually, they improve by itself. Yeah, usually they improve. 80%, 90%, they improve with time. If it doesn't, you can intervene. Any question, Isha? Yes. Okay. This is what I said. Yeah, you can give it prophylactically to prevent it to go into endophthalmitis. Yes, you can do that.